Good evening, and you are in the panel regarding breast reconstruction in Alberta, and we're going to be talking about access, options, and support. So welcome, everybody. And I would like to introduce my co-panelists as well as myself. So my name is Claire Temple-Oberly. I'm a plastic surgeon at the Tom Baker Cancer Center in Calgary. And we have Jen Matthews, and she is also a plastic surgeon in Calgary. We have Lisa Corus, who's a plastic surgeon in Edmonton. And James Wolfley is another one of our team. He just is having a little glitch getting onto our panel, so hopefully he'll join us soon. And he's from Edmonton as well. And then sitting next to me is Antoine Bouchard-Fortier, and he's a surgical oncologist and breast surgeon at the Foothills Hospital here at the Tom Baker as well. And then I see we have Sue, and Sue is a cancer information consultant with the Canadian Cancer Society of Alberta. So welcome to the moderators. This is a listen only mode type of presentation. So we would love to hear your questions, and I'll be monitoring the chat room. So far, I don't see any chats coming in there, but I'll keep a close eye. We have some questions that have been sent in ahead of time by participants. So I think we'll just get started on those, and then I will ask the questions that come in from our specific group. So I think I'll start by asking Dr. Bouchard-Fortier, who's with me here. This is a question that came in. Is it possible for my breast cancer to come back due to breast reconstruction?
Okay, so I would just say usually, breast reconstruction does not cause the cancer to come back. It's usually more prognostic feature of the initial cancer that will be associated with what we call a recurrence, meaning the cancer coming back. So usually when we select patients that are candidate for immediate or delayed reconstruction, there's a thorough process where we go through and kind of come up with a score that is acceptable and linked with a very low risk of recurrence after reconstruction.
This question I'm going to put to Dr. Jen Matthews. The person asks, for a patient who requires radiotherapy post-surgery, is it best to do reconstruction separately after radiotherapy is over?
Thanks, Claire. I think it's a tough question, and I think the answer may differ depending on the patient's situation and maybe the plastic surgeon who they're seeing. But I think that reconstruction can be done before radiation or after radiation, but sometimes it changes the options that are available to a patient depending on the effects of the radiation. So patients are candidates for reconstruction before or after, but in general, we tend to think that tissue type reconstructions tolerate radiation, whether it's before or after the reconstruction, a little bit better than implants. But there are a select group of patients who are still candidates for an implant reconstruction in the setting of radiation, either before or after their mastectomy.
Okay, thank you. Sue, I have a question for you.
Yes.
So I have a patient who asked, how and where can I connect with another woman who has had a breast reconstruction? I just wonder if there's anything available through the society.
There certainly is. We have a very, very supportive online community, which you can have a look at cancerconnection.ca. There are some different forums, just so you know. Under cancer types, there is a forum very specific to breast cancer, and there are several people there posting and talking about breast cancer. So that might be something you're interested in. There are also, if you go to the bottom of the page, there's a link there where you can email a moderator of the community if you are really wanting to zone in on, say, a very specific breast reconstructive procedure, and they may be able to help you connect with somebody. Okay. That's what we're offering right now, as an organization.
Okay, super. I'm seeing some action here in the Q&A. I think the chat function might not be working. Sorry, other than for the panelists. So let me just open the Q&A here. I have a question, and I see we have James Wolfley here. So that's wonderful. Thanks for joining us. This question I will ask of actually Dr. Bouchard-Fortier. Susan asks, I'm wondering how often a woman develops a primary cancer in the remaining breast after previous cancer and mastectomy.
When there's no breast left.
On the contralateral healthy side.
So the risk of a primary cancer on the contralateral side, we usually, if there's no genetic mutation or high risk in the family, so we usually say about 0.5 to 0.6% per year. And that's a little bit what we use for patients. So after 10 years, we can say there's a 5% risk of having a contralateral breast cancer. So that's why we recommend patients to do their screening mammogram on the remaining breast every year.
So I'm going to ask Lisa Kourous, how long typically is the healing process from reconstruction?
Just to unmute myself there. Yeah, so it really depends on the type of reconstruction that you are getting. I think one of the things that I discuss with my patients, whether or not they're getting an implant-based reconstruction or reconstruction using their own tissues, it's more of a journey rather than a one-stop shop. So even if we say it's one stage, it doesn't mean necessarily one surgery. So sometimes people have to go back for tinkering and revisions. And we do know that complication rates are higher after breast reconstruction versus cosmetic breast surgery, where you're starting to, where you work with very healthy tissues. I think a good rule is, 6 weeks after any surgery, a surgeon's going to tell you to be restricted with physical activity, just so you don't pop your incision or pop open some blood vessels. But definitely with some of the abdominally based reconstruction, so our tram and diapflaps, I tell people, even though 6 weeks you're in restricted, sometimes it is a good 3 months before you're feeling yourself again. And then, kind of going back to, you have to consider, well, maybe after 6 to 12 months, we have to go back and do touch-ups, and those, those are easier, but there's still going to be time out of your schedule and making sure you limit physical activity after.
Okay, super. Thank you. So we have a question that I'll pose to Dr. Wolfley. It's a question about breast implant illness. So Rochelle's asking, can you please speak about breast implant illness and the likelihood of that?
I think the big thing to discern between breast implant illness, first, it's completely different than breast implant anaplastic large cell lymphoma. So they share some acronyms, but to talk about breast implant illness, it is something that I do believe in personally. What I usually tell my patients is that we all some people can't wear certain types of metals because it gives them a reaction. And silicone at the end of the day is an element. And so I don't see a reason why that can't potentially cause issues in certain people. So there is a large spectrum of potential symptoms that people can present with breast implant illness. Fortunately, it happens to a very small number of people. But I think at the end, if a workup shows that there's potentially no other issue other than the implants themselves, then I think you just have to make take a hard look at making that decision that maybe the reconstruction is not worth the symptoms you're having. I do offer sometimes a switch over to saline. I think potentially that could be of benefit, and the other option is to switch over to an autologous based reconstruction or nothing at all.
Okay, thank you. And I'm noticing Dr. Matthews is busily answering questions in the Q&A as well. So if your question's in there, she's typed some answers and the whole group can look at that. We have a question from Jody, and it's around ALCL. So I'm going to ask Lisa Kouros if she can consider this question. I have the recalled, so the Allergan BioCell textured teardrop implants. She had a prophylactic mastectomy 5 years ago. My plastic surgeon has said to not remove them, but my family doctor has said to remove them. Would love to hear your thoughts.
So currently with Health Canada, so those implants were pulled off the market, but they were not recalled on implanted women. So basically, we're not allowed to sell them. We're not allowed to place them in women anymore. But the recommendations that came from Health Canada was basically they did not have to be removed from women that had these implants. And the reason for that being is it's still fairly rare. So I think the highest probably statistic that I've seen is maybe 1 in every 3,000 women can develop this cancer. And so I think it comes down to you having a discussion with your surgeon because there is risk in terms of going back for surgery, undergoing an anesthetic, especially if we're trying to take out some of that scar tissue that forms around the implant. There's, a very small chance, but possible to damage lungs and things like that. And, for some women, if they're quite lean, implant reconstruction might be their only option. It doesn't mean that you can't take them out and switch them to a smooth implant, which doesn't have that risk. But basically, that was the recommendation of Health Canada, was not to remove these implants. But definitely, I see a lot of women that come to my office that want to take them out because even 1 in 3,000 is still a risk. And for some people, that's too high, and you've just gone through this journey. You've survived breast cancer, and the last thing you want to be worrying about is having another cancer. But I just think it's worth having the discussion to understand the trade-offs in terms of repeat surgery. Most people do pretty well. They kind of sail through it and are happy in the end. But yeah, it's one of those things that there's not been a blanket recall and everybody has to have them removed. And I have met women that do not want to undergo repeat surgery. And so we just talk about things to look for. So basically, this cancer usually presents after about 8 years, presents as swelling on the breast, so tends to be quite obvious. So things to watch out for if they do choose to keep these implants in.
Okay, super. Thank you. I'll pose this to Dr. Matthews. I've seen you've answered a few questions around lymphedema. Can you remove excess scar with reconstruction in effort to help reduce lymphedema, or is lymphedema risk increased with breast reconstructive surgery?
So just to clarify the question is, can you remove scar tissue to treat the lymphedema?
The question, you could interpret it that way, yeah.
Okay. Yeah, so in general, I don't typically counsel my patients that breast reconstruction will impact your risk of lymphedema. Certainly patients who have lymphedema at the time of their reconstruction, some people anecdotally say that their lymphedema might get a little bit better if they have a tissue reconstruction. In some cases, tissue may be transferred specifically to help with lymphedema. But in general, just operating on the patient and removing the scar tissue doesn't treat the lymphedema. And I would say that patients who are at risk of lymphedema, pretty much at any point in their life, there can be events that can make the lymphedema worse. I would say that reconstruction I haven't found that it generally does that. But in general, it doesn't, removing the scar tissue doesn't treat the lymphedema.
So I will ask James, do women still have to have mammograms after they've had a breast reconstruction?
The messaging that I classically will give patients is that, and again, this is honestly from my general surgery colleagues, that the necessity to do mammography after a total mastectomy reconstruction is not needed. Definitely, I think you need to continue with a self-exam and a physician-directed exam, because if there is going to be tissue left, it's going to be basically at the peripheral margins that can be felt, or on top, just underneath the skin. So all those parts are important to continue. I find a lot of that leads to ultrasounds, just by the nature. But I don't think it's something I don't say routinely. That said, I do see it happen quite a bit. So I feel it's in many ways outside of our it's just done by the family doctors and other people. So.
Okay, super. And Dr. Bouchard-Fortier, what are your thoughts on that?
No, I completely agree with everything that was said. That's exactly, yeah, no mammogram after bilateral mastectomy, physical exam yearly, and then ultrasound if you palpate or suspect something. Yeah, sometimes just a punch biopsy also is skin. It could be done, but yeah.
Okay, super. And we have a couple questions coming up that have to do with COVID. Maybe I will ask Lisa. So, Dr. Koros, we have two women here asking about COVID-related issues, and maybe one you could address. If someone proceeds in this climate right now and gets their mastectomy or lumpectomy and radiotherapy, someone who might have wanted a reconstruction at the time, how are their options now changed that they have to wait for a few months to have elective reconstructive surgery?
So we're talking about more delayed reconstruction in general. Yeah. So yeah, basically right now, I mean, and the rules are changing almost kind of daily, but basically right now to do any surgery in Alberta, it has to kind of fit the criteria as urgent, needing to be done within 6 weeks. And so delayed breast reconstruction, unfortunately, does not fall into that category. And so all those cases have been put on hold. And so unfortunately, I think a lot of those women were canceled with the first wave. We were able to get some of them through kind of the second and third wave. And again, now the fourth wave has been on hold. So we're going to have the backlog of cases that were canceled to catch up with. And then on top of that, the new ones. That being said, I mean, if someone's currently undergoing radiation therapy, most people would not begin reconstruction till at least a year after that, just to allow the tissue time to settle. Yeah, so there's generally not considered a big rush to get to it. Obviously, I mean, we like to get to it as soon as we can, and we don't want to have people wait 3 or 4 years, but yeah, unfortunately there's a backlog. Immediate reconstruction in the setting of cancer, I think, is still happening. In some sites it's modified, just because to do a tram flap, you do require a hospital bed, of which there are none. So women are more often getting kind of tissue expander implant-based breast reconstruction, which can give them a very nice result, preserve the soft tissue envelope, and it doesn't burn any bridges. Say a year or two later, you say, I don't want the implants, I want the belly surgery. We could always convert it as a delayed reconstruction. So there are ways to kind of work around things, but yeah, with COVID, unfortunately, our situation is less than ideal.
How do you decide with the patient whether the implant might go under or over the muscle?
Yeah, so I think for me, I'm almost always still thinking about doing a implant underneath the muscle, at least partially. A lot of patients or people attending might be familiar with the implant being completely under the muscle or partially under the muscle with an acellular dermal matrix sling. For patients over the muscle, for me right now, the only patient population I'm really doing that in are for people who present for their mastectomy and have an implant from an augmentation already in place above the muscle. Otherwise, I think that what factors other surgeons might consider who are doing it over top of the muscle is the patient's body habitus, so the thinness of their skin, because it can relate to how visible the implant might be. And probably the patient's desire or need for the size of the implant. It's generally more reasonable to consider on top of the muscle if you have a smaller breast.
The rest of the body affected by a mastectomy and reconstruction, for example, raising arms, arm strength, sensation, abdomen if flap surgery. So what are the sequelae of the mastectomy and the reconstruction?
Yeah, I think that's a good question. I mean, sometimes we get so focused on the breast, we forget to talk about the other stuff. So for the most part, you can't, Rob, pay Peter or however that saying goes. There's going to be some changes due to any type of reconstruction. On the abdomen, I mean, for that autologous-based reconstruction, I think why it's one of our favorite methods of reconstruction is because if it is done in a DIEP or an SIA type fashion, there is minimal to no muscle injury, and the fascia heals just like a hernia would, and therefore people can resume all normal activities. With regards to a pedicle tram, where you're or kind of a more traditional tram flap where you are taking a larger piece of muscle, then I do tell patients that some of their core strength will likely be diminished. Functionally, probably not noticeable, but for things like sit-ups and kind of strength exercises, they probably will notice something. For latissimus-based reconstruction, the latissimus muscle is the main kind of adductor of the arm, which is not a motion that I tell patients is really common. It's, you know, for rowing, for climbing and stuff like that. But for, again, day-to-day function, that typically doesn't cause a problem. But if they are very active, let's say, you know, with the canoeing or outdoor activities requiring kind of any type of climbing, they definitely will notice some weakness with regards to that. And then even just with a subpectoralis implant, I mean, there is some cutting, partial cutting of the pectoralis major muscle that that will affect some of the pectoralis strength, which again, most likely would just be noticed when you're at the gym or something like that.
Okay, thank you. Um, we have a question here about fat grafting. I see a few questions, and I see Dr. Matthews is typing on one of them. Maybe while she finishes typing there, I'll ask Lisa. So this anonymous attendee had a bilateral mastectomy, reconstruction, radiotherapy, and now her breasts are a little bit malaligned with the radiated side actually being larger. She's wondering about fat grafting. Is it appropriate and safe to use to balance and soften the breasts, and what are the risks?
So these are, both breasts have been reconstructed essentially, is that right?
Yes, bilateral mastectomy, radiation on one side, and asymmetry. Just wondering if fat grafting might be safe.
Because those breasts are still often undergoing mammograms. And one of the risks with fat grafting is you can get cysts, you can get fat necrosis, the fat can calcify, which are all things that can potentially light up on mammograms, which can be concerning. And it depends a little bit on the radiologist reading the mammogram. So some are very astute and can make the difference. But if it's somebody that's not used to seeing a lot of fat grafting, then they might flag those as concerning lesions. But yeah, I find it works well after whole breast reconstruction. Most often just to help with contouring. There's some evidence to suggest that doing fat grafting in radiated tissue can soften that or soften the tissues. But whether that's a guarantee, that's a little bit difficult to say. The other thing with fat grafting, it is also unpredictable. So some people were lucky, put in some fat and most of it sticks around. Some people 50% might melt away. Other people it completely melts away. So some people will have to go through multiple rounds of fat grafting. So it can be a great tool, but it can also be very finicky.
Okay, thank you. We have a few questions, both that were pre-submitted and online now, about inflammatory breast cancer. So Dr. Bouchard-Fortier, can you just briefly describe what is meant by inflammatory breast cancer?
So inflammatory breast cancer is a locally advanced form of breast cancer, and it's basically when the cancer cells have invaded all the dermal lymphatics, and that creates a backflow of lymphatic fluid in the skin, and you get this sometimes redness on the breast skin, and also this peau d'orange. It looks like an orange skin basically, and can be diagnosed with just a punch biopsy of the skin. So usually these patients that have that, it's locally advanced, and we favor neoadjuvant, so chemotherapy before the surgery, and there's usually it associated radiation therapy after surgery. So these are the patients that usually do not qualify for immediate reconstruction, as they have to go through many different rounds of chemo and radiation and quite extensive surgery. So those are most probably patients that will go through delayed reconstructions once they're out of the storm, if we can say. Yeah.
Okay, thank you. Sue, are there any specific resources available for this more aggressive type of breast cancer through the Cancer Society? Any
And which type of aggressive breast cancer are you asking about?
Oh, inflammatory breast
Inflammatory.
cancer, so locally advanced.
Yeah, we certainly have information about it right on our website, which is cancer.ca. And we know about some different supports and things for people as well. So they can certainly feel free to reach out to us if they would
Okay,
like to have some information.
Okay, great. So I'll ask Dr. Matthews. A patient here asked, is breast reconstruction, someone who's had inflammatory breast cancer, is it safe after a couple of years?
Yes, I would say so. I mean, I think we always look to our general surgery colleagues to let us know if it's better to not do a reconstruction. But I think in general, I would say yes. I wouldn't have any worries about doing that.
And another question, somebody asked, when she had inflammatory breast cancer in the past, now why can't she have stretchers, so presumably tissue expanders, and then implants?
So the question is that she's had inflammatory breast cancer, which includes radiation for her.
Yep. And she's
Yeah,
wondering why
so-
she hasn't been advised to have expanders and implants.
Yeah, so it's one of the challenging things when I mentioned about radiation, about how sometimes it can limit your options. When we see someone who's had a mastectomy, so they have a flat chest and then they've had radiation, we know that the radiation makes the skin generally tighter. And for most patients, we would recommend at that point that we use some type of tissue for reconstruction. Although that sometimes we are able to get in a tissue expander and stretch the skin a certain amount, it can be successful in some patients. It in general is quite challenging to get a really nice, aesthetically pleasing reconstruction that a patient is happy with doing a tissue expander. For some patients, the appearance of their chest is reasonable and we can try it. And so it does depend on the patient. So I suspect it's based on the patient kind of variables.
Okay, thank you. Dr. Wolfley, this is a question about pain. Lorraine mentions that she's having some chronic pain in a radiated breast, and she's going to have an abdominal flap reconstruction. And she's asking, will the plastic surgeon be able to remove some radiated tissue and replace it with more abdominal tissue to reduce the amount of pain I'm experiencing? So I don't think she has a reconstruction already. I think she has a post-mastectomy chest, and she's wondering if the abdominal flap will help her pain.
I mean, that's a great question. And I think, pain post-mastectomy and post-reconstruction is probably one of the hardest things to deal with, when you're following these patients long-term. And there are some people, even after reconstruction, who will have considerable pain post-operatively. The process of kind of reopening the flap classically can get rid of some of this really bad radiation scar banding that can develop, and that may help issues. I have on a couple of occasions explored some people who've kind of had really pinpoint pain, and so if you can kind of point to that spot when you're actually seeing the surgeon, I have gone back in and see some actual neuromas, like just right on the chest wall, and was able to kind of try to hide them in a spot that would cause less trouble. But I do think at some point there are some kind of radiation induced neuritis that I wouldn't make any promises that the reconstruction would make better.
Okay, thank you. I have an anonymous attendee asking about psychological implications of either having reconstruction or not having reconstruction at all. So Dr. Bouchard-Fortier, have you had patients that go flat that have been quite satisfied with their outcome?
Yeah, I mean, so every patient is unique and have their own goals and objective, and have different sets of values. So we really try to present the option in a non-biased way if reconstruction is available. But we definitely have many patients that if we can say go flat, and we have some of these that will change their mind and some will stay flat. So I don't think there's any wrong answer there. And some patients, once we send them for just a discussion with a plastic surgeon just to see what the options are, and some, not all of them decide to get reconstruction. So yeah.
Thank you. And Dr. Korus, is there anything that a plastic surgeon can do to make the flat chest more aesthetically appealing for the woman if she wishes?
Yeah, I think so. I mean, general surgeons can as well. Probably the biggest complaint that we see with women coming in after mastectomy that aren't necessarily looking for breast reconstruction is what we call dog ears. And that just, it's related to how much skin you take out. So the bigger the breast, the more skin you take out, the longer that you need to make the incision just to taper things out so that it lays flat. And some general surgeons are excellent at doing this. I have noticed some general surgeons will leave behind the extra tissue because they have the assumption that these women are going on to get reconstruction, or they've expressed interest in reconstruction. And in that case, if you have that redundant tissue, often it will actually blend into the reconstruction. But sometimes you meet with women and you talk to them and you tell them, it's not a one-stop shop, it's a journey, and some people are overwhelmed and want to stick with a flat chest. So then we'll go in and in that case kind of revise. The trade-off is always a longer scar, but most people would prefer a longer scar but have a nicer contour at the end.
We have a few questions around sensation and return of sensation. This person is asking about allograft nerve reconnection done to improve sensation to a spared nipple, or sensory nerve repair, let's say from the lateral chest wall to a DIEP flap. So I'm just wondering if you have any information about that to share.
I haven't personally done any of the nerve transfers for or attempted reinnervation for nipple sparing mastectomies. I would say that in general, after a mastectomy and reconstruction, most of the breast, the chest wall, including the reconstruction, are often quite numb to begin with. And over time, at least the chest wall skin or whatever breast skin is left does tend to improve in sensation, but often doesn't go back to normal. Definitely with the tissue reconstruction, with or without a nerve repair, we do find that patients can get some sensation into that tissue. It wouldn't be described by patients as normal by any means, but definitely some type of sensation where, if we were to do a nipple reconstruction, then freezing is required. But talking to your surgeon about potentially doing a nerve connection with the tissue reconstruction is probably worthwhile. But I'm not able to speak to the nipple sparing or the nipple reinnervation procedure very much, unfortunately.
Okay, that's okay. Thank you. Well, I think we are running out of time. So I wanted to thank our audience for participating with so many great questions. And I think there's been lots of typed answers and lots of discussion. And I want to thank our panel for an excellent, lively, rich discussion. And I think we're going to say goodnight. And if people want to head back to the main holding area, there's an opportunity to join another session. Is that correct, Nee? Great. Okay.
Thank you, everyone.
Thank you, guys. Bye.
Okay, bye. Thank you.
Thanks, Claire. Thanks, everyone.
Thanks, Claire.